इसको बड़ा कर देंगे ये Good morning, students. Today we will be considering the solved long questions of theory questions 2016. We have so far considered 2019, 18 and 17. So we are going to 2016. Just remember, the books are no substitute. You have to give importance to the books. This is a general guideline. So these all 6 questions have come in 2016 from general surgery as well as from systemic surgery. We will try to discuss everything one by one. So first and the commonest question which is always asked in one other way is regarding the varicosity of the lower limb. The subject question is surgical anatomy, etiopathogenesis, clinical features, complications, investigations and management of varicose veins of lower limb. That is, practically this covers everything regarding the concept of varicosity. For that we have to understand why the varicosities are common in lower limb. And the answer is draw line into the anatomical distribution of veins in lower limb. In anatomy, there are basically two types of veins, venous system in the lower leg. First is a superficial veins, more common. Among them, the commonest which we do across is a LSV. That means long or great saphenous vein. We call it LSV or GSV. This is the longest vein of the body. Where it begins, just remember, all these begins at the medial part of the dorsal venous of the foot. Simply put, they originate at the medial malleolus. And then they will ascend up to knee and then go into where? To the saphenous opening. This is the end point. Where does the saphenous opening lies? It is 3.75 centimeter below and lateral to the pubic tubercle. This you should never forget. And what happening here? At this point, this LSV or great GSV is entering into the femoral vein through the cribriform fascia. Okay, so LSV or GSV is terminating into femoral vein. The specialty of LSV is it contains 12 to 20 valves. The valves are for maintenance of a blood flow towards heart. And remember, it is the longest vein of the body. In the lower leg, so LSV is closely associated. Look at the applied anatomy. LSV is closely associated with saphenous nerve. What is the importance? This nerve can be damaged during the surgery of a long saphenous vein. Then comes SSV, that is short saphenous vein. It originates where? This originates from the lateral malleolus. Okay, from medial malleolus, LSV. From lateral malleolus, SSV. And this will go along with the tendo Achilles, it will enter into the popliteal vein. It is a small vein, so it has got 6 to 12 valves. LSV 12 to 20, SSV 6 to 12 valves. This is the anatomy. Other types of veins are deep veins and perforated veins. So superficial vein, deep vein and perforated vein. This is how the venous system is distributed. What are the deep veins doing? Deep veins are tibial, popliteal and femoral veins. And they are called as veins of conduits. What does that mean? They are all draining the blood, ultimately going to the iliac vein, and the long one is inferior vena cava. The purpose of all these venous system is to collect blood and give the blood to IVC, and that IVC will in turn lead into the atrium. So these veins are called as pumping veins, because there has to be some pressure gradient, and that pressure gradient comes from the musculovenous pumps. That means the calf acts as a peripheral heart. So there are venous sinuses which will be pumped by the pressure of calf muscle, that is during walking or the pumping action, and the blood goes to the ultimately to IVC through this pumping action. If this action fails, again it is a cause of some problem causing varicosities. Other veins are perforator veins. What they are doing? They are connecting the superficial venous system to deep venous system. Very important one. That means these two veins has to work together. Why? Because if one of them is blocked, these perforator veins will take over and transfer the blood from one system to the other system. So they are perforators. Perforators are many. For a practical examination, you must know the anatomical dispositions of the perforator. Most of them are constant in position, few are variable. Ankle perforators, lowest one called as May or Custer. Lower leg perforators are perforators of Cocket. 1, 2 and 3. In the lower leg there are 3 perforators. Gastrocnemius, this is important perforator. It is a below knee. And mid thigh, most important, dart perforator. And hunter perforators are high up in the thigh. So these are the perforators. You remember there are approximately lower leg perforator which are most common for us of Cocket and hunter perforate in the thigh. That is how the perforator is. This is a diagram which is showing the anatomy. It is available in all books. But the important part, remember, there are, you can find out there are perforators here. This perforator, this important perforator, these are all perforators. That means they are joining the superficial venous system to deep venous system. In lower limb, as we discussed, there are two systems. One, this is a long saphenous vein. If you find out, it is starting from medial malleolus. Medial malleolus going into the saphenopharynx. Short saphenous vein, see here carefully, it is arising from the lateral malleolus. That means most of the pathologies of lateral malleolus are due to short saphenous venous system. Again, see in the lower leg, there are 1, 2, 3 named perforators. Okay, so this short saphenous vein is entering in by this superficial to the popliteal vein junction. This is the SP junction in the knee joint. Long saphenous vein, see here, starting on the medial malleolus, going above, there are 2 branches and these are the perforators. Why important the perforator? Because during duplex scan, you can mark the perforators or you can palpate the perforators. So if perforators are the basic cause, you have to tie the perforators. This is how it is ascending LSV through the thigh, it is going into the saphenopharynx. And remember, these 3 veins are very important training. Never forget the names. Superficial epigastric, superficial external pudendal, and circumflex iliac vein. These are the important veins which are draining into the LSV and then going into femoral vein. This is for a practical important. So we have considered what is the anatomy of the lower leg. So coming to the proper varicosity. What is the definition? Varicose vein is defined as dilated, tortuous, subcutaneous veins of diameter. Remember, subcutaneous vein of diameter more than 3 mm. All varicosities above 3 mm. Below that, there are different names. And with what? Significant reflux in upright position. Even in standing, there is a reflux. It is difficult in lying down. So, significant reflux in upright position. This is the definition of a varicose vein. 5% incidence, prevalence is 35% in all amongst the population. Among that, severe varicose veins 10%, chronic venous deficiency 8%, and ulcers occur in 2%. We will consider this in detail, but common in women, related to jobs having prolonged standing like policeman, driver, and most common presenting symptom is a heaviness in leg. So, what are the veins now? Causes for primary varicose veins, and second is secondary varicose veins. These are the basic differences. Amongst primary varicose veins, simply remember idiopathic, familiar, hereditary. If you write down three things, you are through. For a secondary, again for the obstruction. For a secondary varicose vein, common cause is obstruction of a venous outflow, destruction of valves. The function of valve is the directing the blood flow. So the destruction occur where? In DVT. So this deep vein thrombosis is one of the cause of a secondary varicose veins. Remember with these two, forget about rest. And for obstruction, anything in the pelvis which cause pressure over the inferior vena cava will indirectly lead to the obstruction. And common causes, pregnancy, mass, lymph node ascites. Remember only pregnancy and pelvic mass. Okay. High pressure AV fistula, these are also important cause. And now artificial AV fistulas for dialysis are also common cause for varicosities. So remember, varicosities are more common in lower limb wall. Why? Because of erect posture and long column of blood. Long column of blood has to be supported for a long time throughout your life, and that is leading to the weakness and incompetency of wall due to either idiopathic or secondary or a familial cause. This is very common and undergoes in the families. Okay. Now what are the pathogenesis? Why do they occur? Simply remember only few things. Definition we have discussed: dilated, tortuous, elongated veins. It is a permanently elongated. Remember, varicosity is a permanent elongation and dilatation. The risk factors for pathogenesis are hereditary and female sex because of the hormonal position and pregnancy. Occupation. Occupation does what? Prolonged standing, immobility, and in sport they say raised intra-abdominal tension, tight clothing, raised progesterone and altered estrogen levels. So this is related to estrogen progesterone ratio. For an old age, chronic constipation, and they say high heels also one of the cause because high heels reduces the pumping action of a gastrocnemius. So high heels should be avoided whenever possible. Flat surface is much better for action of a gastrocnemius, that is second heart of the body. Primary varicosities, congenital absence or incompetence of wall. So major cause congenital is wall. If there is any problem with the wall, the blood will not go to the femoral vein, it will be stagnated there. Muscle weakness is also one of the cause, and for secondary varicosities, it is thrombophlebitis. That means DVT is the one of the most important cause. Occupation, obstruction, pregnancy, and congenital or acquired IVT, that means iliac venous thrombosis. So coming to clinical picture, we have considered anatomy, we have considered the etiology, primary cause, secondary cause. Okay. Now the clinical features. Remember only two classifications. In fact, you can remember only one. LSV varicosity, SSE varicosity, and varicose vein due to perforator incompetence. So this classification is regarding the anatomical as well as one of the pathological. Other classes are given like the depending on the size. Thread veins 0.5 to 1 millimeter, reticular varices 1 to 3 millimeters, and our varicose veins are more than 3 millimeters. Okay, 0.5 to 1 thread veins, 1 to 3 reticular, and more than 3 it is varicosity. Why this important? Because there are different types of treatment available for different diameter of veins. So this classification. Coming to the symptomatology. Common symptoms are there, remember only few. Dragging pain. This condition is very important. You feel as if you are lifting your weight and put it. It is exactly against the pain of claudication. This dragging pain means it is a dull lacking pain, postural discomfort, and the heaviness. These are the common signs. They can occur in any condition for that matter. Night cramps. They are usually late night, patient has to wake up because of the dull lacking pain. Edema. itching, discoloration and ulceration. These are all symptoms of a varicose veins occurring at different levels. The causes of cramp in varicose veins are mainly what they say, it is the increased venous wall tension, and this condition is now getting importance called as chronic venous hypertension. Now this is the buzzword of today. All varicosities cause is chronic venous hypertension. Like systolic hypertension, this is a venous hypertension. That is why all these problems are occurring. So treatment also changing accordingly. What is it? Increase capillary pressure. More important among the symptoms is the cutaneous manifestation. What are they? It is a disturbance into the leukocyte adhesions and accumulation in venous wall, and they are causing the vascular skin lesions in a varicosity. Okay, so it is mainly types of vein, the clinical feature of dragging pain, edema, and the cutaneous manifestation. Why does the edema occurs? This is due to localized or generalized edema at the ankle flare. All the varicosities are starting from ankle. The long syphilis from medial ankle or medial side and short syphilis from lateral side. Because of long-standing stasis, there occurs cellulitis and lymphangitis, and this is the cause of edema. Long-standing edema gives rise to what? It is a thickening of the skin. That condition is called as lipodermatosclerosis. This is a sign of a chronic varicose veins, and this sign is called as inverted champagne bottle appearance. How the champagne bottle looks in inversion, that is, ankle becomes narrow due to contraction of skin and subcutaneous tissues, but calf remains prominent. This is inverted champagne bottle appearance in chronic varicosity. Okay, there can be more other conditions, and remember one thing, whenever there is a familial varicose veins, it appears at a younger age group. Remember, younger age group, always think of familial. And the patient will tell his father had varicosity, the daughter will say my mother had varicosity. So are these the younger age group? Bilaterality. Many times it is unilateral disease. In congenital, familial, bilateral, and involves all veins. That means superficial, the short syphilis, long syphilis, and perforated. All are involved into familial. So we have come to the familial predisposition clinical signs. We will discuss in detail afterwards. I will show you some graphs where you can simply understand what the whole thing is going about. Signs is simple. Visible dilated veins in the leg. These are the signs. Pedal edema, pigmentation, dermatitis, these are all the skin signs. Remember few of them. In some cases, there can be bleeding. Bleeding is also one of the presentation of a varicosity. Because of a stasis of blood, even minor trauma can cause excessive bleeding. Above that, the condition is called as periostitis of the tibia. Chronic inflammation of the periosteum of the tibia can cause periostitis, that means tenderness over the tibia. What is the sign? Positive cuff impulse at the saphenofemoral junction. It is lying where? 3.75 lateral and below the pubic tubercle. Saphenopharynx is, it is a large varicosity in the groin which becomes visible and prominent on cuffing. This is same like a hernia presentation, but site is different. Okay, so this is what we are called as a saphenopharynx. If you can remember this chart, I think you can write down everything regarding the clinical features of a varicose vein. In practical, in theory, both ways. So what are the tests and how do you classify? This is the latest classification. What are the tests? First, there are three primary causes. What are they? First cause is saphenofemoral incompetence. That means it is high up. It is where the LSV joins the femoral vein. that is a sphenoferal junction incompetence. Second is all along the veins perforator incompetence, where they lie perforators between the superficial and deep venous system. And third and most important diagnosis cause is DVT, that is deep vein thrombosis. So if long-standing thrombophlebitis DVT will give rise to varicosities. So our job is to differentiate between the pathology, because on this pathology treatment will differ. So what are the clinical tests for sphenoferal incompetence? Very simple. Remember for practical. Trendelenburg 1. Morris's cuff impulse test. This shows sphenoferal incompetence. That means the blood is coming from above to below. Next, perforator incompetence. This you have to identify which perforator. And this test is called as Trendelenburg 2. One is for sphenoferal incompetence, two is for perforator incompetence. Okay. And what are they? These are the multiple tourniquet test. The tourniquet applies according to the anatomical predisposition of the perforator veins. Other test is Pratt test, Fagan test. Even you remember the names, very good. But you should know something about Trendelenburg 1 and 2, how they are performed. Deep vein thrombosis, you must identify DVT before any treatment is undertaken for varicose veins, because DVT is a contraindication for any surgical intervention of a superficial venous system. One system you are removing, other already blocked. That is why we should not operate. So what are the tests? They are all called as Perthes test. Perthes, modified Perthes, Homan sign and Moses sign. So these are the names given for the diagnosis of DVT. They are mostly related to the calf, forefoot function and calf function and squeezing of the calf. Now they are not done commonly because it is afraid that squeezing of gastrocnemius or calf may may lead the emboli to dislodge and go into chest. That means pulmonary embolism. That is why these tests are avoided. Okay, so this is regarding the test, and this is a different classification. We have considered classification of short saphenous, long saphenous, and perforator. This classification is called as CEAP. Name itself is diagnostic. C stands for clinical, E stands for etiological, A stands for anatomy, and P stands for pathophysiology. This classification is all-inclusive classification. Clinically, what? C0, no clinical sign. C1, small varicosity. C2, large varicosity. C3, edema. C4, skin changes without ulceration. We are going step by step. With ulceration, C5. And skin changes with active ulceration goes to C6. So this is a clinical classification. Etiologically, we have considered congenital, primary and due to DVT. So this is the etiological class. So there are three etiologies: congenital, primary and secondary. Anatomical. This is beautiful classification. They have considered superficial vein, deep vein and perforating vein. That means all we discussed so far, this chart or CP classification showing everything. Pathological, first is reflux, other is obstruction. Reflux means reflux due to faulting of the perforator veins. Obstruction means obstruction above into the pelvis, like the commonest cause is pregnancy or some thrombosis into the iliac system. So remember this page, you have gone everything regarding the anatomy and clinical features of a varicose veins. So this you remember by heart, forget rest. Again, this is a beautiful chart. Simply put, what are the investigations? Now see the changes. Over the time, every management is changing. And what they say, all clinical or phlebological tests have been superseded by Doppler test. So what? The Doppler test is considered as a clinical method now. So what tests we have so far considered? Trendelenburg 1, 2, Perthes, Schwartz, Pratt, venous Doppler. These are the clinical tests. You must be able to demonstrate this clinically. So this is Doppler is for the management. For the diagnosis, you should never forget the clinical methods. They are simple and can be done by bedside of the patient. Venous Doppler is for doing what? To find out DVT, siphenofemoral incompetence, perforator incompetence are the we are doing it venous Doppler. Venography not done now. Air plethysmography, duplex scan, these are all reliable and ultrasonic Doppler imaging techniques. So this is in short all the investigations we have considered. Next question asked was complication. So what are the complications are? Hemorrhage, pigmentation, venous ulcer, Marjolin's ulcer. Remember, Marjolin ulcer can be a short note. What is it? It is a change of ulcer, chronic ulcer into malignant squamous cell carcinoma. This is called as Marjolin's ulcer. It occurs in long-standing varicose as well as in post-burn. Post-burn ulcer also gives rise to Marjolin's ulcer. So this is for short note or MCQ. Lipodermatosclerosis, that means painful lesions of the leg. Ankylosis, talipus, DVT, wall calcification, and above all, recurrent thrombophlebitis. These elongated veins are not going to sit like that. They will give recurrent thrombophlebitis. That requires the management. Treatment has to be done. Okay. So these are the all different tests. You can go through that. So these are all for the clinical knowledge. Remember only one. For Brodie-Trendelenburg, one number, vein is emptied by elevation of the limb. Tourniquet is tied just below the sphena varix, that means spheno-femoral junction. Patient is asked to stand quickly, and when tourniquet or thumb is released, rapid filling from above. Rapid filling from above signifies what? Spheno-femoral incompetence. This is test 1. And against that, 2. After standing, tourniquet is not released. See the difference. 1. Release the tourniquet. The fluid will come from above to below. In 2. Tourniquet not released, but in spite of that, the filling of the blood from below upwards observed within 30 to 60 seconds. And what it signifies? Perforator incompetence. So this test itself is a beautiful manifestation. Other tests are Schwartz, Pagans, Pratt, Boris's, earbuds, and examination of the abdomen. Never forget this part, because one of the major cause for a secondary varicosity is abdominal pathology. Investigation we already considered in that our graph. All the investigations are clinical and physiological, that is a Doppler test. So this is the identification of all the investigations. You can go through at leisure. So the management. Again, management rests in 2 types, conservative management and operative management. Conservative is crepe bandage, elevation of the leg and pneumatic compression. Drugs commonly used are calcium dobesilate, diospin and toxirutine. These drugs, calcium dobesilate particularly gives very good result. So what it does? It will change the stasis. These drugs are mainly aimed to remove the stasis of blood into veins for a longer time. So we are going to the different non-surgical management. Injection, sclerotherapy, it is a Fagus technique. So this is a sclerosant injection. Indications are uncomplicated or recurrent veins indicated for the sclerotherapy. How does it act? The sclerotherapy causes aseptic inflammation. Then this important for a short note also, it is a foam sclerotherapy by Tessari. This can be always asked. Where this is taken in a syringe. That means sclerosant is taken in syringe and foam is created with the help of another syringe, which results in formation of foam. How do you do it? 1 ml of a solution, what is called as a nowadays available, is the 4 ml of the solution, 1 ml and 4 ml of air. So this is going to make 5 ml of foam. This STD will go into 5 ml and is injected into vein. Maximum total 6 ml of at one time and 30 ml of foam. That means you can do it for 5 veins. This is for the sclerotherapy. It is a foam sclerotherapy of Tessari. Okay, there are different techniques. Microsclerotherapy, complications do occur because of this sclerotherapy like blackening and ulceration. That is why sometimes it is not very popular. Surgically, Trendelenburg operation, it is called as crossectomy. This surgery is the stripping of vein. What is the name of stripper? Meyer stripper. What are you doing? Stripping the vein from below to upwards. And we rarely go for stripping of short saphenous, but it is done from ankle to upwards. Okay, these are the two stripping. Other systems are superficial ligation, ligation of SSV, and minimal invasive are many like SCPS, RFA, and EVLA. This is the mainstay of today. This system is a laser fiber. This is a endovenous laser ablation of a vein. This is a commonest done at present, and anesthesia is tumescent anesthesia. So this is in short. We will also consider now. These are the graphs we should remember. This will put everything in short. Clinical signs: telangiectasia, reticular veins, saphenopharynx, atrophic blanch, that means whiteness, lipodermatosclerosis, eczema, and ulceration. These are the skin signs of varicose veins. What is the management? Conservative management of venous ulcer is called as Bisgard's method. This is also for short term. If there is a bleeding from ulcer, what are we doing? Is a lifting of the leg will arrest the bleeding. So surgeries for, you can remember this chart. Surgeries, superficial ligation, where we are going for long incision and every perforator is ligated. Superficial ligation of the perforator, varicose vein surgery, Trendelenburg surgery, and in Trendelenburg, the nerve at risk is saphenous nerve. That is why we are stopping stripping at ankle. All the stripping is only up to ankle now. It is up to knee joint. If you go up to ankle, you are damaging the saphenous nerve. What are the complications of surgery? Wound infection, nerve injury, thrombophlebitis, but recurrence is comparatively high in short saphenous vein as compared to GSV or long saphenous vein. Patient who are or high BMI, that means obese patient, and if the recurrence occurs, the surgery is AVLA, that means endovenous laser ablation is the surgery of choice. So at present it is the mainstay of the management. So again this simple graph: treatment, first conservative. How do you do it? Elevation, pneumatic compression, calcium dubulate, injection sclerotherapy Figan technique, Tessari technique, transillumination microsclerotherapy. This is we are given in short. Surgery, Trendelenburg, stripping, superficial ligation, invasive, Trendelenburg, recurrence is known, infection, nerve injury, and common peroneal nerve may be involved, and thromboembolism. These are the shortcomings. So, non-invasive management, Tessari, SCPS, radio frequency ablation, that is RFA, and endothelial ablation is now a gold standard, and it has replaced conventional surgery ligation and stripping. It is also cost effective because it can be done under local anesthesia. That is called as tumescent local procedure. So for this two method, laser and radio frequency. Simply write down this much and you have got flying color. So this is RFA and AVLA. So these are the main names for management. So we have finished our discussion regarding the varicosity of a lower limb. Surgical anatomy, clinical features, etiology, recent advances, surgical procedures, conservative management, and the clinical signs. So now we go to our second question. This is one of the probably most important part where everybody asks in their lifetime and he faces the patients. So what is the question is? Write etiology, pathology, diagnosis, current nomenclature, TNM staging, clinical features, and management of early and advanced carcinoma of breast. So all these you have to go very seriously because in this lecture I am trying to cover all types of the clinical features of early and late malignancy of the breast. We'll consider everything, including anatomy, the lymphatic drainage. So even for short note, you don't have to be confused. You can simply write down anything regarding malignancy of breast by going through our these short notes. Okay. So in general, the introduction. So what is the incidence? Is sporadic cases, that means without any cause, 65 to 75. Now we are always talking about what? Familial breast cancer. That means breast cancer running in families. It is 20 to 30%. Remember the seriousness of taking history of the patient. Hereditary breast cancer, 5 to 10%. Amongst hereditary, what it is? Now the buzzword is BRCA 1 and 2. BRCA 1 is more common, 45% of is hereditary. BRCA 2, 35%. And chromosomal mutation of 50 is 53 mutation, more than 1%. Do you know what is BRCA stand for? BRCA stand for BR for breast, CA for carcinoma. BRCA is breast carcinoma 1 and 2. Simple. So BRCA is not a very big thing. It is a breast carcinoma shortcut. And here we are talking about the hereditary. Other symptoms or other congenital conditions: Peutz-Jeghers syndrome, Cowden disease, Muir-Torre syndrome, Alexia, and now very important is, what is it? It is HER2 mutation. Now what has happened? The basic concept of a loco-regional malignancy from CA breast has gone to systemic malignancy. That is why everything has changed. The moment cancer occurs in the breast, it is simultaneously spread to other parts of the body. So it is our duty to find out at earliest where it has gone. If it is not there, well and good, we are dealing with the early breast carcinoma. But if it is above that, we are dealing with advanced carcinoma of the breast. So management differs from day one. So HER2 mutation, invasive breast carcinoma, 80% of them are ductal carcinomas. And unfortunately, HER2 mutation has got a poor prognosis. P53 mutation, again poor. And they are resistant to chemotherapy. This is the introduction to the whole thing we are going to discuss. Smoking and oral contraceptives in young female is an increased risk of malignancy. Don't be afraid, it is not very high. Combined HRT with estrogen is a higher risk. And the pills which is only estrogen, they have got a lower risk. That is why gynecologists are prescribing only estrogen. Progesterone is avoided. Decreased menstrual cycle due to lactation per se reduces the risk. First degree relatives, 2 to 3 times more risk. And how do you calculate? There is a model. These model of risk assessment are called as Gale model and Claus model. We will consider the Gale model, which is commonly done. What are the types of carcinoma of breast? Simply remember. Types are carcinoma in situ, CIS. Lobular carcinoma of the breast, this is LCIS. DCIS is ductal carcinoma in situ. This is past. But now they are thinking LCIS is not a major malignancy. So for us, it is DCIS and invasive carcinoma are left to us. Types of carcinoma of breast, carcinoma in situ and invasive carcinoma. Okay, these two basic types. So just discussion: most common cancer in urban women in India. Most common form of malignancy is adenocarcinoma. This, if you remember this, you are through. Most common is invasive ductal, that is serous carcinoma. Least common, papillary. Most malignant malignancy of the breast is inflammatory breast cancer. And among them, the prognosis is in tubular carcinoma, the prognosis is best. Bad prognosis, inflammatory breast cancer. Good prognosis, tubular. After carcinoma is bad itself, but you can be having more of a 10-year survival rate. Most common site is upper outer quadrant. Least common site is lower inner quadrant. Okay. And remember, the carcinoma is more common in left breast as compared to right. This is general observation. Not that right do not have malignancy, but left has got more chances of undergoing malignant changes. The cause is not known. So lower inner quadrant, least common. Metastasis. Most common metastasis is bone. And where they are? Deposited into lumbar vertebra, femur and thoracic. So that is why back pain or severe bone pain may be the presentation of a CA breast. So the old ladies, our mother, grandmothers complaining of a severe backache always give a thought to carcinoma of the breast, where the secondaries have come to lumbar vertebra first. And just to inform you, the most common cause of death is malignant pleural effusion. So how do the patients die? For a CA breast in late stages, it is malignant pleural effusion is a principal cause of death. So how do the mets travel? From cancerous breast, they go to posterior intercostal veins. From there, they are going to the vertebral veins. From there, dural veins and then going to brain. That is why brain secondaries are also very common. This is about the general idea of how we are dealing with. So coming to the etiological factors. This you have to write in exam. What are the risk factors? In red I have written most important risk factor is age. What this signifies? The malignancy is much more common in older age and the prognosis differs. Risk factor is age. If the malignancy occurs in younger age, bad prognosis. Malignancy occurs in old age, better prognosis. So this is the risk factor is age. And how do they classify? These are the etiological factors for CA breast. It is everywhere now. The risk factors are always divided into 2 or 3 categories. Modifiable, non-modifiable and histological. Modifiable you should consider give more importance because you can change them. Non-modifiable, diagnose them early because you cannot change it. What is in our hand? Earliest diagnosis by screening method is for the modifiable, non-modifiable diseases. Understand or diagnose cancer at earliest. And what is histological? Always go for histopathology of all risk-prone lesions. So what are the cannot be modified? Increasing age cannot be modified. Menstrual factors, age at menarche less than 12 years, late menopause above 55 years. This factor also cannot be modified. Family history BRCA 1 and 2 cannot be modified. Race ethnicity cannot be modified. And if there is history of radiation exposure, you cannot modify, you have to face it. What we are going to do here? Earliest diagnosis by the screening method. You are not to be afraid of it. If it cannot be modified, it can be diagnosed earlier. So the aim of screening method is to identify non-modifiable cancers at earliest and treat them. That will increase the 5 and 10 years survival rate. What are the modifiable factors are? Age at birth of first child, if it is more than 30 years, here we can encourage early motherhood. Parity, nullipara woman, there are less now. See that they get more and more by different methods. Always consult them, examine them. Absent breastfeeding, this is a psychological factor. Encourage the breastfeeding. Obesity can be taken care, tobacco can be taken care, alcohol, night shift, decreased exercises, and hormonal replacement drugs. These all can be avoided or modified. Okay. Histological, what type of breast disease it is? In proliferative breast disease, lobular carcinoma, this proliferative has got a bad prognosis. Lobular carcinoma, now not considered, has got a better prognosis. So these are the different causes. So this chart, I think if you remember, we have done a lot of yourself and you can answer. Simply don't go for a long work. What we are always talking about, nulliparity, age of menarche, late menopause, they have got slight to moderate risk. Remember, these things have a very slight risk. Even obesity, alcohol, HRT, they are got a risk factor, but not up to the mark. You should be conscious not to do it, but it is not a major risk. They are slight to moderate risk factors. Moderate to high risk, here it should be given importance. Always consider malignancy age above 60 years. You should be conscious. If there is any history of repeated biopsy, that is history of DCIS, ductal carcinoma in situ, always it is a high risk. Cancer on one side of breast, be aware patient can develop on other side. So these are the high risk. Above all, very high risk, family history. You must always ask the family history. In two first degree relatives, the increase of the malignancy are very high. Similarly, ovarian cancer has got equally high risk of malignancy. See, the God is not leaving you like that. If you have ovarian cancer, you stand chances of developing breast cancer. It is a bad thing, but it is a high risk. You must be aware. And what is to do the fact? We are calling nowadays as a prophylactic mastectomy. And where BRCA1 and BRCA2 mutation carrier or first degree relative with mutation, P53 mutation, they are the candidates for prophylactic mastectomy. We are doing our best. Against the nature we are trying to fight. So these are the risk factor classification. And what is the pathological classification of the carcinoma breast? Because they may ask the pathological classification. What is it? Classification of a primary breast cancer. Remember, primary breast cancer can also be secondary. Never forget, secondaries can come into breast. First is non-invasive. Basically, there are two types. Either it is a non-invasive carcinoma or it is an invasive carcinoma. Okay. All the breast cancers are epithelial malignancy. This you must always remember. They are epithelial malignancies. LCIS and DCIS. LCIS is now considered non-malignant. DCIS means intraductal, ductal carcinoma in situ. What are the types? Papillary, solid, cribriform and cuboidal. This is a pathological classification. Invasive are invasive lobular, not very malignant, 10%. Invasive ductal, they are the commonest and they go up to 70%. Remember only these two, invasive lobular, invasive ductal. 10%, 70%, this you can forget. But one thing you should not forget is medullary variant, that is a basal type. Why this medullary variant? This medullary word whenever comes, it has got a very high pathogenicity. It is highly malignant and chances of survival are very dim. If you remember in thyroid, medullary carcinoma thyroid has got a worst prognosis. Here also medullary variant basal carcinoma has got a worst prognosis. So this epithelial and connective tissue, apart from being epithelial, connective tissue can give rise to malignancy. What they are? Mixed connective tissue and epithelial tumors. This is very important because we are dealing with the condition of a phyllite tumor. This phyllite tumors is very interesting. It is very bad condition. Breast becomes at least 5 to 6 size number of times the breast and recurrence is very common. That is a phyllite tumor. It is a mixed connective tissue tumor. There can be carcinosarcoma, that means sarcoma changes can occur in the connective tissue. So basically it is epithelial and connective tissue tumor. Epithelial are more than 95% and others are just 5%. Okay, so we have gone for risk factor classification as well as pathological classification. Now go into the clinical factors. So this is in short, you can just remember this: risk factors, first degree relative, breast cancer in contralateral breast. Here we are talking of a higher grade of malignancy. BRCA1-2 gene mutation, obesity, alcohol, nulliparity, early menarche. These are associated causes, but these are for a very bad purpose. So we talked about the risk management model. Commonest we are considering is modified Gale risk assessment model for a CA breast. What does the risk management say? Ask the patient, age of the patient, age at menarche, age at first live childbirth, and race. It is more common in black. Number of first degree female relatives having breast cancer. This is how you have to ask the history for a Gale factor. Never forget this question. how many times the previous breast biopsies are done. Many of the time breast biopsy comes negative. So number of time breast biopsy done is also among the risk factor. And proliferative lesion with atypia, that means atypical lesions goes in favor of malignancy. So what they are doing? Their risk factors are translated into risk scores. So the score patient has to earn by specified calculations, but unfortunately this Gale model is not getting inclusion of the genetic factor. For today it is a major cause. So this Gale model itself has got some drawbacks. So this is also a good classification. If you remember this classification is also for the management. It is called as a pragmatic classification. If you remember this, you can write down the management also, what we are going to do. If this is a type of classification, what is the management? And what are the chances of survival? So, primary, that is very low risk, primary breast cancer, more than 90% chances of 5 years survival. Low risk, 70 to 90%. High risk, if you call it high risk, less than 70%. And locally advanced has got less than 30% of the malignancy. And metastatic, you cannot assure anything. Example are screen detected DCIS, that means very low risk. What is done here? The cancer is diagnosed during screening program. See the difference. You have diagnosed it without manifestation in screening. That is why you have got 90% chance of 5 years survival. That is why the screening program has got its own importance. And treatment is very simple. It is a local excision. Okay. For this low risk, nodal negative. That means the axillary nodes are negative for malignant changes, favorable. The treatment, loco-regional excision with or without systemic. Node positive status, loco-regional with systemic management. Large primary or inflammatory, that means advanced malignancy. There, the primary management is systemic management. Surgery has got a second role. Okay, so this gives you an idea about what is happening, what is the management. If you remember this much, I think you are enough. But I may add something for your interest. LCIC, that means lobular carcinoma in situ. Priorly, it was included malignancy. This American Journal of Cancer Management or Cancer Club has removed. LCIS now considered as a benign condition and not treated as a carcinoma unless it goes into change into DCIS. Even high-grade lobular carcinoma are not included. There are different types, 20 more major, forget about it. What is more important for us in examination and understanding is a pathological classification. The pathological classification of the new era or today is called as a molecular classification. So we have got so many classifications: clinical classification, pathological classification, age-related, and now comes the molecular classification. You have to remember this, unfortunately. Why it is so important? With this molecular classification, you can treat what is called as a targeted and individualized treatment program. Nowadays, one of my mother has got malignancy, my sister has got malignancy. Their treatment differs. Understand? Even if they are related, one patient's malignancy carcinoma breast diagnosed, another patient diagnosed, but the management differs. And why? Because of the molecular type of their malignancy. This is more important for management because it is the individualized treatment. You are giving treatment as per the malignancy, not as an individual. Okay. So we are considering the pathological classification as a molecular classification. So this is simple. This is for MBBS. How do you stage a breast cancer? This unfortunately you have to remember. Early stage, stage 1, 2A and 2B. These are all TNM classifications. Locally advanced, 3A, B and C. And for 4, it is distant METs. Even if you remember this line, I think you have got more marks. You are through. Early stage 1, 2A, 2B, locally advanced, that means LABS, locally advanced breast malignancy. 3A, BC and 4 is distal. Okay. So what is our doing? These are all the classification you can read at leisure. For stage 3B, up to 2B is alright. For 3B, it is a grade 4, locally advanced. And they are called as T4 diseases in stage 3B. And stage 3C, all N3. N3 means nodal status. How many number of nodes are there? And this is what is called as the molecular classification of CA breast. If possible, try to remember. They may ask sometimes. It is one luminal A cancer, luminal B, HER2 and basal type. This is a basic qualification. Here the prognosis differs. This classification is mainly dependent on the prognosis. Fortunately for us, luminal A is very common. What is here? HER2 negative, ER negative, PR negative. ER means estrogen receptor, PR means progesterone receptor. They are positive, but HER2 is a negative. What is happening here? Good prognosis, and these are all associated with BRCA2 genes. Okay, so BRCA2 genes are better than BRCA1 gene. Luminal B. What the B stands for? Here it is a triple positive. That means HR positive, ER positive, HR positive. This is a triple positive. That means everything is attacking, and this has got a poor prognosis. Why this? What they differentiate? The pathology is taking over your resistances. So it is all positive, triple positive. A bad prognosis and triple negative, worse prognosis. So anything triple is not good. So poor prognosis, and this is also associated with BRCA2. HER2 positive, ER negative, ER positive, negative. These two negative, one positive, again poor prognosis. But basal type, that means medullary. Here everything negative. HR negative, ER negative, PR negative. It's condition called as triple negative. Here it is triple positive, triple negative. Triple positive, poor prognosis. Triple negative has got a worst prognosis. And remember these two things. For all luminal malignancies, associated BRCA2. BRCA2 has got a good prognosis. And here it is associated with BRCA1. Basal type is triple negative BRCA1. It has got a very bad prognosis. So this is how you have to remember. BRCA1 bad prognosis, BRCA2 sometimes good, sometimes bad prognosis. It depends on the triple positive or triple negative. Okay. And triple negative cancer means what? If they ask you short note, that means in tumor markers by microarray analysis and immunohistochemistry. They are asking. Immunohistochemistry is for ER, PR and HER2 receptor negative status identified. And this medullary cancer, I told you, very bad. Metaplastic, all have got bad prognosis. Why very bad? Because there are no targeted treatment available. So, and they are associated with BRCA1 mutation. So remember only triple positive and triple negative. Okay. Now we go to the latest AIGC 8th edition TNM staging. If possible, remember TNM staging, TIS, that is DCIS and Paget disease. Paget disease of nipples. 8th edition has removed HCIS. T1 more than 2, less than 2 centimeter. T2 more than 2 but less than 5. See here, less than 2 and more than 5. T3 more than 5. T4 tumor of any size with local extension. Extension where? To the chest wall or skin. T4A chest wall extension but does not include pectoralis major. T4B edema, that is PUDRH, involvement of skin, is a T4B PUDRH, ulcerations and satellite skin nodules. They also go for T4. T4C, both T4A and T4B. And the worst comes T4D. What it is? Inflammatory carcinoma of breast. It has got the worst prognosis among the TNM staging. I think you can remember this. 2 centimeters, 2 to 5 centimeters, more than 5 centimeters, and wherever there is extension to chest wall. This is the simplest 1, 2, 3, 4. End staging, N1 metastasis to ipsilateral. That means same side lymph node. Metastasis to axillary nodes and fixity. Fixity will make it N2A. Only clinically apparent but clinically evident absent N2B. Medicine ipsilateral infrascapular N3A. Infrascapular scapular lymph node, they also go for a higher malignancy. N3B, medicine ipsilateral internal mammary nodes and axillary nodes together. N3C, medicine ipsilateral supraclavicular. This makes it inoperable. It goes to stage 4. And M1, as usual, distant metastasis, either M0 or M1. For M1, you have to go for long list of investigation. So this also sometimes or always asked. You must remember this. What is the lymphatic drainage of breast? For a short note as well as in long question. So this lymphatic drainage depends on the level of nodes. Level 1, it is, remember, most of the nodes are related to pectoralis minor relationship. First, remember this simply, pectoralis minor is a major denominator. Lateral to lateral border of pectoralis minor is stage 1, level 1. They are anterior, posterior and lateral. That means subscapular, pectoral and branchial. Right now only anterior, posterior and lateral. Simply put to the pectoralis minor. Level 2, behind pectoralis minor. You are going behind it. And the nodes are central or interpectoral. They are called as rotorous node. So this is level 2. Level 1, lateral to pectoralis. Level 2, behind pectoralis. Level 3, medial to medial border of pectoralis minor. This is simple. You can remember. Lateral 1, behind, that means posterior 2, and medial level 3. Okay, this is what is called as a staging of the breast cancer. And apical infraclavicular has got a bad prognosis. Apical also comes in level 3. Apical means infraclavicular. This is the last lymph node we are usually removing. And for sentinel lymph node, sentinel, that means SNEB, sentinel lymph node biopsy, there is a buzzword today. And that lymph node is called as Giuliano's node, is for the sentinel node. Okay, and just remember what node in carcinoma breast? Spread restricted to level 1. It has got a clinical significance, has got a better prognosis. Spread to level 2, poor prognosis. Spread to level 3, worst prognosis. That means one of the prognostic factor for a CA breast is axillary infiltration. Lymph node above number, that means lymph node above 4 carries bad prognosis. Okay, so this is regarding the lymphatic drainage of breast. You should never forget this. And this is the diagram for book where they are showing where there are level 1, level 2, level 3. Simple. This is pectoralis minor. Lateral to it 1, behind it 2, above it 3. All lymph nodes are here 3 above, 2 and lateral this number 1. So these are the surgical level of lymph nodes in the axillary draining of the breast. You remember 1, 2, 3 also? Good, very good. You are getting a rank. Okay. And now, what is a triple assessment of breast? Sometimes they ask, what is a triple assessment? Clinical assessment, a radiological imaging and pathological examination. So these three combined, clinical, radiological and pathological, triple assessment gives positive predictive value of diagnosis which exceeds 99.9%. So you have no chance of missing anything. Clinical, radiological and pathological. It is a triple assessment for CA breast. This is a buzzword of today. Okay. Now the basic system, sometimes they ask what it is of BI-RADS. Also very commonly asked. What is the BI-RADS system? This is nothing but a breast imaging and reporting data system. How do you report the carcinoma breast? And what is the importance? Yeah, this system is used to suggest pathological examination based on findings. So, this BI-RADS, if it is less than 3, it does not need pathological investigation. This is important. BI-RADS, breast imaging, reporting and data system. Short note can be asked. So, what are the categories? There are 6 categories. 0, 1, 2, 3, 4, 5, 6. What they stand for? incomplete assessment, negative assessment, benign findings, probably benign, malignancy suspension, highly suspicion, and known biopsy. So these are the 6 grades. And what is importance? In grade 0, you need further investigations, observation, negative, annual screening, because you cannot say one patient cannot develop, so it is a screening. Again, annual screening is recommended for benign findings, and if there is any doubt whether it is benign or not, probably it is benign, any question mark, you have to go for short interval follow-up. Now coming to grade 4. Any suspicion, biopsy is a must. Okay. So from grade 4, biopsy investigation starts. Grade 5, you have to take immediate action. Of a suspicion suggestive of malignancy, you have to treat it. Biopsy proved, again you have to treat the condition. So this is the importance of a BI-RAD system for a short note of a carcinoma of the breast. Now, so far we have moved around all the systems of investigation. Now we will go to what we are day-to-day facing. So this is called as a clinical presentation of a CA breast. Very common. Remember few things? Okay. The buzzword is early breast cancer may be asymptomatic. So what is our duty? Is to diagnose asymptomatic breast cancer. That is where the doctor comes into role. And what are the symptoms which may indicate malignant change? Which patient will tell? Common is change in the size or shape of breast, skin dimpling, nipple retraction, duct discharge, particularly blood stain. These are the clinical presentation. Axillary lymph node enlargement. Some patient may come with axillary lymph node enlargement. Possibility of metastasis. Always keep in mind, any lady coming above up to 50 years with some symptoms. Commonest are bone pain. Bone pain should not be taken lightly. It is acute tenderness over bone. Breathing difficulty, secondaries into chest. Hypercalcemia, secondary going towards adrenal. Hypercalcemia is very bad. This is a terminal event case of carcinoma of the breast. Abdominal distension, what it denotes? Ascites. Secondaries. Jaundice, again secondaries in liver. And see that whether the cancer is at one place or two places. So cancer multifocality, that means same quadrant has got two malignancies. Multifocality. The distance should be within 4 centimeters. Few people say 5 centimeters. Multicentricity. Second cancer outside the quadrant of primary, and it should be away by 4 to 5 centimeters. Okay, these are all clinical presentation. Here it is showing that outer upper quadrant 60%, medial upper quadrant 12%, medial lower quadrant 6%, and 40%, 10% into lateral lower quadrant, outer lower quadrant. Remember why it is very high into this? Because the mass itself of outer upper quadrant is maximum, and this nipple area complex has got 12% chances of malignancy. Never forget. Paget disease is one of the most common pre-malignant condition occurring over that. So other symptoms are lump in breast, hard, painless, and never forget, at least tumor should become 1 centimeter to become clinically palpable. Okay. So for if 1 centimeter palpable, if it is not palpable, you have to investigate. And investigations are many. Second, nipple discharge, ulceration, fungation, axillary lymph node, all these signs. So pain in lump can be occur, and there can be secondary ovarian tumor. Okay, and always examine with the arm raising up. That will make the lump in the breast more prominent. So other manifestations apart from lump, cutaneous. Cutaneous manifestation commonest we see is a PUD orange. Why does it occur? It is due to obstruction of a dermal lymphatics, opening of the sebaceous glands, and hair follicles get buried in the edema, which gives rise to orange peel. That means the peel of an orange. So it is called as PUD orange. Dimpling of the skin, because of what? Because of the ligament of Cooper. there is a tethering to skin. Retraction of nipple due to infiltration of a lactiferous duct. Remember, all these cutaneous manifestations are making it grade 4 malignancy. Infiltration to the skin or infiltration to the chest wall makes it grade 4 malignancy. Okay, so that is why you must give importance. Ulceration or any discharge from the nipple, skin ulceration, skin fungation. They are locally advanced breast carcinoma, and the condition cancer and cuirass, as if there is a my patient is going for a war. The whole arm is so thick. What it is? Skin over the chest wall and breast becomes studded with cancer nodule appearing like a armor coat. That is a cancer and cuirass. So again levels we have just now discussed. They are called as Berg's levels. Level 1, 2 and 3. So these are must 1, 2, 3 simple. And usually again I told you spread to number 1 better prognosis, spread to 2 bad prognosis and spread to 3 worse prognosis. So lymphatics and clinical condition give rise. So investigations, common investigation we will go through. Just headlines and you can discuss detail afterwards. Investigations are of choice today is a mammography. What it shows? Microcalcification signifies malignancy. Soft tissue shadow is irregular. 50% of the breast cancer on mammography are seen before they are palpable. Remember, this is below 1 centimeter. That is why it is the best screening test. And unfortunately, it has got more importance above 45 or 50 years of age, when the breast size itself becomes small. Larger the breast size, breast mass, this mammography may not be held. So below 35 to 40, mammogram is not advised. Why more common? Non-invasive and less radiation exposure. Second is USG of the breast. What USG shows? Irregular margin, irregular interlacose, irregular posterior shadowing and non-compressibility. The other benign condition can be compressible, but malignancy is non-compressible. And this is for the higher level. The ratio between AP and lateral diameter is more than 1. That means there is a growth, anterior posterior growth is more. Second investigation is FNAC, everybody knows about it, fine needle aspiration cytology. Nowadays, importance is given to core cut or true cut biopsy, and above all, frozen section biopsy, which is taken in case of sentinel lymph node biopsy. The other biopsies are excision biopsy, edge biopsy, whenever there is ulceration or fungation, and estrogen receptor study. This is very common now, immunohistochemistry. They are estrogen sensitive receptors, ER and PR. If they ask short note, write down. The tissue is kept at low temperature in ice block. And how much temperature? It should be minus 70. If you remember, nowadays vaccine available for corona also has to be kept at minus 70 degrees and it cannot survive for more than 5 days. This is the latest news. So our ERPR again at minus 70. Simply remember the value of significance. If value of more than 10 units per moles of a gram, it is called as ER positive. If value is less than 10 units, it is ER negative. Why ER stands for estrogen? Remember in English and American English, estrogen starts from E. In India, we start from O. British language, O. So this E stands for estrogen, not OR. It is ER. So OR and E stand for both ER, PR. So ER is estrogen and positive and negative. Less than 10 units negative, more than 10 units positive. This is most important prognostic indicator. So again PR status. So PR or HER2, what is HER2? HER means human epidermal growth factor receptor 2. This has got the importance of a what you call as a triple negative. HER stands for human epidermal growth factor HER2 or they call it NEO2. So this is oncogenic and overexpression of HER2 is good. HER2 positive is better because this is going to respond to chemotherapy of adriamycin. Next investigation, you have to study the discharge. Here again, the sentinel lymph node biopsy, SLNB, this also can come as a short node. What is it? It is the first axillary node draining the breast by direct drainage is designated as a sentinel lymph node. And this involvement, if positive, it is the first lymph node which will be involved by secondaries. And if the facility is not available in many centers, so that is unfortunate part. Now comes to the management of a CA breast. There are two basic principles. Remember, for all carcinomas, in fact, our aim is to remove the cancer to minimize the chances of local recurrence. You are removing it. Why? Remove the chances of local recurrence and minimize the risk of metastatic spread. These are the two aims. So what happening? For early breast cancer usually involves surgery with or without radiotherapy. Once you go to locally advanced, it is systemic chemotherapy called as adjuvant chemotherapy. So at the end, you start from early breast cancer, go to the end. It is a locally advanced or metastatic disease is usually treated by systemic therapy, and it is what to palliate the symptoms, and surgery like excision playing a much smaller role. Early breast cancer, primary surgery; advanced breast cancer, surgery there has got a secondary role. So in short, the carcinoma breast management is called as multidisciplinary team approach. Okay, and mastectomy is indicated for large tumors in relation to size of the breast. Central tumor beneath one multifocal diseases. Now the change has occurred. The carcinoma malignancy is considered in relation to the breast size. More the breast size, large tumor same. Small breast size, large tumor, bad prognosis. You are getting it? So younger age comparatively large tumor has got a better prognosis. Old age large tumor has got a bad prognosis. So it is a size. I think we should concentrate on this graph from the Levant-Bailey, which gives us every clear idea about the management. Algorithm for the management of operable breast cancer. You can remember this. Achieve local control by appropriate surgery. What is appropriate? Wide local excision, mastectomy plus radiotherapy, combined therapy, and wait for final pathology of the receptor management for chemotherapy. Treat risk of systemic disease. This is more important. How are you going to do it? Chemotherapy if prognostic factor is poor, and include Herceptins if for H2 is positive. Herceptin is a drug very costly. Radiotherapy, hormonal therapy. And for early breast cancer, our aim is cure. See how the change. Advanced carcinoma, it is to prevention. Early breast cancer, cure. It is likely in some cases, but recurrence is more. Local disease control in the breast and axilla, that means local regional management, and delay the chances of a distant metastasis. This is the aim of management. I think we are somewhat late, but this graph you must always remember. This is very simple and this gives idea of everything. Surgical aspects of a cancer breast management. So what are the different choices? Simple mastectomy, radical mastectomy, quad therapy, breast reconstruction, nipple area sparing mastectomy, MRM, that is modified radical mastectomy, and BCS, that means breast conservative surgery. In short, it signifies all type of management of the breast carcinoma. And adjuvant therapy protocol. What is the protocol? Where the patient is standing, stages of breast cancer. Early breast cancer, MRM, BCS. LABC, locally advanced breast cancer, stage 3 ABC, no adjuvant chemotherapy. That means first start the chemotherapy to reduce the disease, make it under control. Then MRM plus radiotherapy to the local part, not to the axilla. If there is a distant mets from the start, you have no choice actually go for hormonal or chemotherapy. So this whole page is signifying or writing all the management system of a CA breast. Remember only this one. All other will just go in short. Surgeries for simple breast we have considered. What are doing in petty modification? Axillary vessels, Bell's nerve also removed. MRM has advantage where pectoralis major is not removed, hence good blood supply. So shoulder function preserved is the advantage of MRM over the mastectomy. So this radical mastectomy was a key word in the past. The name is Halsted mastectomy. They may ask sometimes. But now present concept is no more Halsted radical mastectomy. This is today's word. But you must know what was done because this Halsted has saved millions of female from going into death earlier. His concept was locorenal malignancy. Now the concept is systemic malignancy. So what he had done in Halsted in radical removal of breast tissue with nipple area complex. See, he has removed whole breast with level 1, 2 and 3 axillary lymph nodes. What again he has removed? Very major surgery. Pectoralis major, pectoralis minor, serratus anterior, latissimus dorsi, subscapularis, external oblique, upper part of rectus abdominis. Simply imagine the severity of the surgery. He has done it in millions of cases. He must be appreciated. Now it is difficult for us to think. What he has preserved? Axillary vessels, Bell's nerve and cephalic vein. These are the structure preserved. So these are removed and these are preserved. Disadvantages? It is a mutilating surgery and reconstruction is not possible. In our days, we used to go for skin grafting afterwards. Primary closure is not possible. Lymphedema is very common in this case, disadvantage. Cosmetic results poor and complications are many. Axillary problem, hemorrhage, flap necrosis, wound infection, lymphedema and sometimes lymphosarcoma, that is malignancy over the arm. Injury to the nerve like intercostal nerve, long thoracic nerve of Bell, what it will cause? It will cause winged scapula and latissimus dorsi paralysis. So what is complete Halsted operation? This is a radical mastectomy with removal of fat, lymph nodes, pectoralis major, pectoralis minor, entire breast with tumor and skin over breast, nipple of axilla, areola. This is complete Halsted. And this is a graph. See how much of the incision we have removed. Practically everything. This is a dissection plane going up to sternum. And lower border, it is going up to the abdominal wall. So this is what is totally removed in Halsted operation. Not done very commonly. But you must know what he has done. Patich mastectomy modification and BCS. BCS is buzzword of today. What it is? It is aimed at removing the tumor plus margin of normal breast tissue. This is commonly called as a wide local excision. And we do remove axillary content by a separate incision. Okay. And we are removing only minor grade 2 or sometimes level 3 lymph node. Usually 1 and 2 are removed. If the patient is having some problem in biopsy, radiotherapy is given where? To the chest wall. And adjuvant systemic therapy. And now hormonal therapy and chemotherapy. Simply remember these two types, you will be getting maximum marks. So this chart will finish with this today. It is late. These two graphs you must remember. They are from the book of this surgery book Das, and we call as a simply BCS. This is BCS is breast conservative surgery. You must remember this. What are the indications? Node less than 4 cm. Clinically negative axillary nodes. Mammographically detected lesion. That means early detect lesion, very good. Well differentiated tumor with low phase. Adequate size breast. Breast size should be adequate. Why? To allow local radiotherapy. And feasibility of axillary dissection RT to intact breast. Okay. So these are the indications. What are the contraindications? Tumor size more than 4 cm. Positive axillary nodes. Tumor margin is not free. Poorly differentiated multicentric tumor. BCS is not possible. And tumor breast size ratio is more. That means if the tumor is larger than the breast size can compare, then the BCS is not advised. If the breast has received previous irradiation, BCS is not advised, and tumor is beneath the nipple, again BCS is not advised, and extensive intraductal carcinoma. These are the contraindications. So what is the treatment strategy for CA breast? Stage 0, that is DCIS, ductal carcinoma in situ, less than 4 cm. Wide local excision, radiotherapy, hormone therapy. What hormone therapy we are giving is very commonly used. Tamoxifen 20 mg per day orally for 5 years. Only after menopause we are not giving tamoxifen. So for 5 years. More than 4 cm, total mastectomy with our lymph node biopsy, that means sentinel node, and if positive you have to go for dissection. These patients can receive hormone therapy. Okay. Stage 1 and 2, early breast carcinoma. BCS plus RT plus the central lymph node, positive axial dissection. If tumor less than 1 cm, positive axial lymph node, high nuclear, ER/PR negative with overexpression of HER2, then adjuvant chemotherapy. So this is an advanced classification. If ER/PR also considered, if they are negative, go for adjuvant chemotherapy. That means this patient is going to respond. Stage 3, palliative management, neoadjuvant chemotherapy, and followed by MRM, followed by RT, followed by chemotherapy, plus hormonal therapy, that is a targeted therapy. Stage 4, hormone therapy. This is very costly. It is Trastuzumab or Leptinib. I told you MAB or NIB. When they come to local, it is a targeted therapy. Cost is more than 16 to 20 lakhs per annum. With chemotherapy using taxanes. Taxanes are comparative cheap. Plus toilet mastectomy whenever there is function. This is how the treatment strategy of carcinoma of breast as per the latest model. So today we have considered all different aspects of the malignancy of a CA breast. Next question we will consider in next lecture. So thank you very much, and I am grateful for your patient hearing. Please try to make use of all these in your practical classes. Okay. Thank you. Thank you. Good.